Hello, can you hear me? Yes. Good evening, bonsoir. My name's Erica Lehrer. I'm a faculty member in the departments of history and also sociology, anthropology here at Concordia, and I also hold the Canada Research Chair in Museum and Heritage Studies. A center that I direct, which is listed as CEREV, but actually it's recently been renamed the Center for Curating and Public Scholarship, is one of the co-sponsors of tonight's event. And we are also hosting a related workshop with Jennifer Brier tomorrow from noon until 2 o'clock in this building on the 6th floor. And if you are interested in that, you should speak to Tom Waugh, who's up here at the end, to sign up, as there are limited spaces. It's my great pleasure tonight to introduce the first event in the 23rd consecutive season of the Concordia University Community Lecture Series on HIV/AIDS. Bienvenue and welcome to all students, faculty, community volunteers, and members of the public. The Concordia HIV/AIDS project takes as its mandate to reach the diverse Concordia University community and also the greater Montreal public, to maintain a permanent space for interdisciplinary dialogue and research on HIV/AIDS for the region, to challenge the Academy to confront the societal crisis engendered by HIV/AIDS and to expand its educational mission, to develop awareness of social, scientific, and cultural aspects of the pandemic through community education, internal dialogue in the Academy, social criticism, and the encouragement of volunteering and activism, and to nurture the next generation of HIV/AIDS researchers, activists, teachers within today's student population. So before the lecture begins, some thank yous are in order. So first, our sponsors, without whom this evening would not have been possible. Community sponsors of our series include AIDS Community Care Montreal, QPERG Concordia, the Farha Foundation, Head and Hands, COQ SIDA, Portail WIHS SIDA de Québec, Canadian HIV Women's Sexual and Reproductive Health Cohort Study, the Center for Gender Advocacy. And for tonight's event, we have partnered with the following Concordia University units as well: English, History, Philosophy, Political Science, the School of Community and Public Affairs, Sociology and Anthropology, Journalism, Religion, Physics, Cinema, the Faculty of Fine Arts, and the Office of the President. I don't think there's almost anyone we haven't partnered with here. That's fabulous. We would also like to recognize our principal sponsors of this evening, Vive Healthcare and the Consulate General of the United States in Montreal. We would now like to welcome Consular Officer Robert Revere to give a word of welcome for the evening. Thank you.
Good evening, bonsoir, bienvenue. Permettez-moi de vous remercier au nom du Consulat général des États-Unis à Montréal de votre présence ce soir pour la présentation. As a representative of the Consulate General of the United States, which is a co-sponsor of the event tonight, I would like to welcome you and to thank Dr. Thomas Waugh and his team, as well as Concordia University for the presentation tonight. The number of people here tonight and the interest in Dr. Brier's work speaks to the broad awareness of the social and scientific aspects of HIV and AIDS in Canada. In the United States, President Obama recently updated the national HIV/AIDS strategy to increase coordination across the federal government and to ensure that all Americans living with HIV and AIDS will receive support at every stage of their illness. AIDS was first identified 34 years ago. The United States and Canada have played pivotal roles in the scientific and policy aspects of the fight against HIV and AIDS. Some of our accomplishments include support for life-saving antiretroviral treatment, HIV testing and counseling for pregnant women, and recently in 2010, the elimination of the ban on allowing HIV-positive travelers and immigrants into the United States. Nous avons travaillé assidûment avec le Canada pour éliminer l'interdiction de voyage et nous travaillons encore de concert pour lutter contre la stigmatisation associée au VIH-Sida. So once again, thank you for being here this evening and enjoy the presentation.
So I'm just going to explain the schedule for tonight. The presentation by our speaker will last approximately 1 hour, and then we've allotted 30 minutes for questions after the talk, and I'll explain how that will be organized when we get to that point. We do ask that everyone please turn off your cell phones for the duration of the presentation, if you haven't done that already. And also consider making a tax-deductible donation to the lecture series, as we rely on small contributions to make this happen. I would like now to welcome Dr. Alexandra de Pocamandi, the principal investigator of the Canadian HIV Women's Sexual and Reproductive Cohort Study at McGill University Health Centre, who will introduce tonight's honored guest and speaker. Thank you.
Good evening, everyone. So, I was invited to introduce the guest speaker of tonight because I'm an HIV clinician working at the Chronic Viral Illness Service of the McGill University Health Centre. And I also lead the CHIWO study. And I'll just take a minute to introduce the CHIWO study. Thanks. So the CHIWO study is a cohort study across Canada which recruited 1,427 women living with HIV. 352 of these women are in Quebec. The goal of the study is really to assess if women are receiving the care they actually need and if the offer fits the women's need. The study is conducted under a CBR principle, or participatory research principle, since its design stage. And each interview performed at every 18 months is done by a trained peer research associate. So it's been a great experience and a great collaborative work. Participating women were recruited in community organization, through networks of the women living with HIV, or through clinics. So I feel that this project has been great, not only for the potential results we'll get to improve the care for women living with HIV, but just the collaborative work between social science researchers, medical researchers, women living with HIV, community organizations. So it's been a great experience. I actually, because I know some of them are here in the audience for the peer research associate, and I'll take the opportunity to say how wonderful they are and how extraordinary work they have done, and I really appreciate it. So in this context, I'm very delighted to present tonight's guest speaker. Dr. Brier is an associate professor at the University of Illinois at Chicago, where she's the director of the program Gender and Women's Studies, and she also has a joint appointment in the history department. Her research and teaching largely focus on exploring the historical intersection of gender, race, and sexuality. She specializes in U.S. gay and lesbian history, history of sexuality, and public history. In 2009, she published her book, Infectious Ideas, U.S. Political Response to the AIDS Crisis, in which she describes how activists, service providers, philanthropists, and the federal government responded to the AIDS epidemic in the 1980s and 1990s. In the Gender and Women's Studies program, Dr. Brier teaches many courses, including Sexuality and Community, Sexuality and Culture, AIDS, Politics and Culture, and feminist knowledge production, among others. In addition to her teaching and research work, Dr. Brier co-curated with Jill Austin the exhibition Out in Chicago, an award-winning exhibition on LGBT history in Chicago, presented at the Chicago History Museum. She also co-edited the anthology that accompanied this exhibition. Tonight, she will present her current work on History Moves, a major public history project in Chicago, which partnered with the Women's Interagency HIV study, WIHS, to collect the story of 14 women living with HIV in Chicago. So please join me in welcoming Dr. Jennifer Brier. Let's see.
Thank you so much. I'm really honored to be here. This is quite this doesn't happen in Chicago. Like, the consular general doesn't come to introduce me. The physics department doesn't even know who I am. I am really honored to be here today at Concordia with its amazing history of interdisciplinary scholarship on HIV/AIDS, the Concordia HIV/AIDS project that Tom runs, the Center for Oral History and Digital Storytelling, the Center for Curating and Public Scholarship. It's kind of like for me, it's like an intellectual and political jackpot that doesn't happen very often, where you can engage with people who are interested in thinking about HIV as a cultural and political phenomenon, as well as one that's a medical and health phenomenon. And to be able to do it in a space that really recognizes the power that history can have when it's outside of a classroom or outside of an academic book, for me, is really quite exciting. So I'd like to thank Tom for inviting me in the first place, and Katie Zozula, who really managed to get me here. There was a moment when I did go to the United Terminal this morning and there was no ticket, but then I realized I was really going to Air Canada. So it was all okay. I've spent the better part of the last decade imagining what happens when the history of sexuality or queer history meets public history. And this has culminated for me in a series of public exhibitions and programs, presentations that seek to detail and immerse audiences in myriad queer pasts. And that was really the goal of Out in Chicago, the exhibition that I worked on at the Chicago History Museum. And it was really, for me, an opportunity to step outside of my own sense of history as an academic historian and imagine what happens when you change the audience that you're speaking to, or at least you sort of try to imagine anew the things you think you know about the past. And in part, my work in public history was in some ways a way for me to take a break from the history of HIV/AIDS. And we could talk about this. I would actually love to talk about this with people who work in the field of HIV/AIDS in one form or another, in part because I was just sad, and I was angry, and I was tired, and I didn't want to do it anymore. I wanted to take a break and do something else. And that was a luxury for me in some ways. But it turns out that what happened was, when I changed the way I thought about history, I was able to enter anew into the work on HIV/AIDS because I felt sort of freed and liberated to do something different. And in part, that was because I was joined by a whole new cast of characters in this work that I'm going to talk about tonight. Graphic designers, architects, healthcare professionals who are deeply committed to feminist practice of public health for women, much like the work that's being done here at McGill. I think the WIHS is probably your counterpart, and I'll talk about it a little bit, well, a lot actually. And it brought me a new sense of possibility, a way to look anew at this complex subject of queer sexuality, HIV/AIDS, and women's lives, which I think sometimes got lost for me. The women's lives piece sometimes got lost for me in the first half of my work on HIV. And to do it from this different perspective, and it sort of just made things possible for me. And the first place that happened was working on this little traveling exhibition. In 2012, the U.S. National Library of Medicine, which is housed at the NIH, the National Institutes of Health, which is the largest entity doing health research in the United States. It's the federal site that does all of the work, contacted me to see if I was interested in creating a traveling exhibition on the history of AIDS. And the curatorial process forced me to return to work that I had done for Infectious Ideas, but to think about it in this different form. And at the most basic level, I took a 200-page book and distilled it into 3,000 words. That's being a little bit hyperbolic, but that's okay, and about 25 images that now sit on these 6 panels. And there's Gaëtan Dugas right there at the top of that orange panel, who is probably one of the most famous Canadians, infamous Canadians, in the history of HIV/AIDS. And I should say that what we did in that panel, and we could talk about it if you want, was really talk about how the myth of patient zero was made through sociological public health research. And I based that on a book that's being finished by a historian named Richard McKay, who's written a book about looking at Dugas and thinking about how his stories, how his experience as a gay man across Canada in the 1970s and 1980s was never really captured in Randy Schultz's And the Band Played On. That's what we did there. And it has an accompanying website that has many of the posters of the federal government or things that have been funded in part by the state. And it's going to go to over 100 libraries in community spaces around the United States, like Leavenworth, Kansas, and Gainesville, Florida. Not the sites of, not New York City. I mean, it will be in New York City. It's been in Chicago a couple times. But I'm pretty sure, and the evidence has sort of slowly come in, that it's some of the first and only history of HIV that most of its viewers will ever encounter. And the exhibition argues, as did Infectious Ideas, that biomedical solutions were not and will not be sufficient to address the HIV/AIDS pandemic. Put more sharply, political and cultural solutions, including humanist ones that involve literary and historical and artistic interventions around questions of subjectivity and healthcare, must be part of how we approach both the prevention and treatment of HIV/AIDS. And I make this argument, obviously, in part because I came to the study of HIV not as a medical historian, but as a political historian and a historian of sexuality, but also because I'm committed to understanding what it means to say that health is more than the absence of disease, a phrase with a long history that I think we really need to figure out how to document, display, and make meaningful, in part through the experiences of people living with HIV/AIDS. And so to do that, the exhibition's main aim is really to convey that people with AIDS were and are at the forefront of changing how we understand and fight AIDS. I worry sometimes that argument about the agency of people with AIDS gets lost. It gets lost in newspaper accounts. I mean, we hear about apathy more than we hear about anything else. And in part, I've been trying to think about why that happens because, of course, I haven't found apathy in the way that it's been described. And scholars like Debbie Gould have done pretty, I think, very important work on how affect helps us understand the evolving course of the AIDS epidemic and the response to it. But I also think that this story of apathy is sometimes, it's caused by two countervailing and paradoxically connected ideas. One is the sort of omnipotent narrative of medicine, which makes it seem like if you're not following exactly what medical advice says, then you're apathetic or you're not engaged. So you sort of think about the fact that, well, if this many people don't get tested, or then the people who've gotten tested and test positive access care or remain engaged in care, who gets to a viral load of 0? If you think about that as the way that you measure apathy, it's almost bound to prove apathy because it doesn't really ask the questions about how healthcare responds to people with AIDS, and it doesn't ask questions about how people with HIV, living with HIV and AIDS, think about their own access to care. And I felt this, and this is perhaps sort of too centered on myself, but I felt that sometimes when I went to the NIH to do this historical work, like I would go to the library and other people would go into labs, and it was somehow like they were doing work that was really pressing and I was just like studying some stuff from before. And how that feels, what it feels like, I think, to be a scholar working on HIV and not to have an epidemiological background, not to have a medical background, and how to understand and think about how I can contribute to work about the sort of healthcare around HIV right now in the present, even as I'm looking at the past. And it's sort of interesting because the way that that often gets described is that through decreasing stigma. And the President Obama's plan, which I've read quite closely, in part because I was applying for some funding, and it seemed to be the best way to make a case for what we were doing, is very much about how do we limit or ameliorate stigma. And of course, the problem with the language of stigma is that it doesn't necessarily understand structure, right? It understands how something manifests itself on an individual body. And so I had this conversation with the funder who said, she said to me, I guess I want to know why you think a history project could make any change. What's your theory of change, she asked me. And of course, at the time, I was so shell-shocked that I didn't know what to say. Instead of saying, well, I'm a historian and I believe change happens, that was my theory of change, I was like, oh, that's an interesting question. And then she said, why should we fund anti-stigma work when we can buy folks medicine? And it was like this moment of just, I was sort of like, confronted with the reality that that is the model, is like if we get to a point where we actually fully accept, I don't think we will get to this point, but there is something about what's happening at this moment with treatment as prevention, with questions about PrEP, with questions about sort of how we're going to use meds to solve AIDS, which is both part of a demand that was made through parts of AIDS activism of the 1980s and 1990s, but also, like, the reality is it's not going to ever do that. It's not going to be effective by itself because it doesn't understand that there are a range of things that cause AIDS, that make HIV/AIDS a global pandemic. And so it was sort of like, well, stigma so history work or meds. And I thought to myself, like, why are we even accepting that this is a possible zero-sum game? Like, we have no choice but to imagine that it's something much more than that. And so there's this one side of biomedical supremacy that I've been talking about in different contexts and that I remain very concerned about, and that I would very much welcome the opportunity to talk about and think about with you. But I also think, and this is something that I'm struggling with, I think that there are ways in which the way we've narrated the history of AIDS activism, particularly in the United States, but not entirely in the United States. Maybe it's the history of ACT UP, which is, of course, an international movement, and the sort of most radical manifestos of ACT UP and ACT NOW are produced here in Montreal in 1988. But I wonder about the subjectivity of many people living with HIV/AIDS, particularly women living with HIV/AIDS, and how that gets overshadowed also by the way we, and I include myself here, have narrated the history of direct action organized to fight AIDS. What kinds of action, thinking, change-making does this kind of activism drown out? What can't we hear or see because we focus on activism that we define as this? Right? So what happens when we do that? And part of me wants to say, like, I don't want to give this up because this is some of the most important queer activism of my lifetime and all of our lifetimes. But there is something that happens in that moment, and I want to just make sure that we don't miss these other, I don't want to call them smaller. I don't even have the right language yet, so maybe we can talk about that. But what happens when you make decisions about what you're going to focus on when you say you're going to focus on activism? So this photograph is from 1990 in front of the Department of Health and Human Services. And it has the look of an ACT UP protest circa 1990, because that's what it is. But of course, this was a protest that was about expanding the definition of AIDS to include women. And what you don't see, if you don't know to look for it in this picture, is in the back right corner. Yeah, the back right corner is Iris de la Cruz. She's all the way at the end with that little piece of white paper right in front of her. And the first time I saw this picture, I didn't see her, which is what upset me when I then did see her. I was mad at myself for not seeing that when I first saw the picture, because I saw the picture for what I wanted to see the picture for, not for what else was there. And so this was an amazing protest. It was a demand to expand what treatment and prevention needed to and still needs to look like as the HIV epidemic has spread. And we know from a range of scholars' work, Tamar Carroll's work on New York, Sarah Schulman's work at the ACT UP New York, the ACT UP Oral History Project, the work of queer theorist Anne Kvekovich, the sociologist Stephen Epstein, that people with AIDS put their bodies on the line to obtain access to treatment, and in the process created the conditions for antiretroviral drugs at the same time that one of the unintended consequences was, of course, not just of the activism, but that coincided with the expansion of big pharma in a way that I don't think anyone fully could have predicted. And so what it means to think about that relationship between this movement for making possible the notion that you could have a cocktail that you could take of drugs, and all of the sort of big macro level globalization and economic transformations that were put in place by the Clinton administration that basically made big pharma the biggest, the biggest industry, global industry that we have today. But the focus of this particular protest, as I said, was to expand the definition of AIDS, to include the symptoms and physical manifestations that affected women. So adding to a list of opportunistic infections like pneumocystis pneumonia or Kaposi sarcoma, to include also cervical cancer, which was something that obviously did not affect men or male-bodied people, but did in fact affect women. And I went back, as I was writing this passage, this section here, I went back and read some of the oral history work that Sarah Schulman's done with Terry McGovern, who is the lawyer who ultimately fought the Social Security Administration around this definition. And I looked back at what she said, and she was sort of talking about what happened between 1990 and ultimately January of 93, when the US federal government changes the definition, not just to include cervical cancer, but to also include bacterial pneumonia, pulmonary tuberculosis, and anybody under 200 T cells. So this was a huge debate, like, do we just talk about T cells, or do we include a range of different infections? Because the reality was that by including T cells with this list, not only were you able to capture many women who were dying of AIDS, but also intravenous drug users, because of the way different kinds of bodies respond to the advancement of HIV through the immune system. And this poster, of course, is from that same event. Women don't get AIDS, they just die from it. And this was really a very powerful slogan, because it made the case that that women were dying and they weren't able to get access to care. They weren't able to get access to the welfare system or to the state. They weren't able to get access to social security in the United States. And it was really, I think, one of the most profound transformations. And then I was reading Terry McGovern's interview, and she says, so in 1993, the number of cases of AIDS in the United States expands exponentially. But it's because of this. And no one talks about what happened in 1993. It's not, and I include myself, it's not on the radar in the history of moments. It's not one of those watershed moments. It's not 1996. It's not 1985 with Rock Hudson. It's not 1992 with Magic Johnson. 1993 is a moment that has sort of been lost to our historical site, in part because it's a moment where it seems like something's gone wrong, but in fact, something has gone very right. There's been an expansion in the way that we understand it, and it's because of women activists like Iris de la Cruz, many of whom were living with HIV, and Iris de la Cruz had been a sex worker and an IV drug user, and she joined ACT UP and then died not long after this photograph was taken, who made the case to expand the definition of AIDS. It was actually women with HIV, women who were dying from AIDS even though they couldn't be diagnosed as having AIDS, who made that change possible. And it's true, and I don't mean to make it sound like men didn't do anything. When you read the oral histories of this campaign, you see some of the most intense collaboration between men and women around this. So you'll read examples or recollections of women saying men were in the office until 2 o'clock in the morning working on this campaign, and there was a real sense of camaraderie across, in this case, across class lines, across race lines, and across gender lines. And I think that that's an important piece to really think about. But then I really do sort of wonder, what is the takeaway from this? And how does this sort of affect the work that I do right now with women who are living with HIV? And one of them is to say to myself and to remind myself that women were at the start of the epidemic and have been at the forefront of imagining and demanding mechanisms for treatment and prevention. But also that the activism of ACT UP cannot stand in for the activism and the change-making work that happened in the United States around HIV. It did not necessarily change the lives of some of the most disenfranchised people with HIV/AIDS, a point I'll talk about in a second when I play some of these oral histories. But also that, again, how we might start to think about 1993 as a watershed moment. And then when I realized that and went back and listened to these interviews, I realized that the WIHS study that I work on, or I work with, the Women's Interagency HIV study, starts in 1993. And so it sort of raises this question about what does it mean to have a women's history of HIV/AIDS, and how would we mark it by time, and what would happen if we started to make a vellum map that had history and medicine, and we started to sort of see what happened when they were put together. And I think it really also raises, and I would say the other thing about 1993 is that it's also a moment that's long been thought of as sort of the end of ACT UP. It's like one of these moments where, so Bill Clinton is elected in the United States, and there's this sense that maybe things are going to change, and then it becomes pretty clear almost immediately that it's not, and people are dying. There's no effective treatment in 1993. And it hasn't been that way, and by 1993 it's been years of that. And I think people are there's a kind of despair that that I remember, that I've read about, that I think maybe some people in this space could talk about. But I just think that it also raises this question, and this is a question that I've been thinking about for a long time, is what is the relationship between what we define as direct action activism and service provision, and what happens when we oppose them and don't imagine some of the possible links that might in fact be there. And in particular, what does that mean for people who really need a particular kind of service provision because of the realities of the fundamental inequities that are stitched in to the welfare state, that are stitched into the way we, in the United States at least, responded to HIV. And so these women's protests really suggest a need to expand our sense of social history, to include this wider possibility. And to also think, and this is where I sort of came to as I was working on this talk, and I forgive me for it not being fully realized yet, but as importantly to think about what survival means in this moment. So, Michael Callan has died by 1993, or maybe not quite yet, if my mind worked well. But he's talked about by then certainly notions of surviving and thriving, and what it means to have survival for the women that I'm going to play you some of their oral histories, I think really does sort of raise some pretty important questions about what the history can tell us. So this is, I have the book itself. Oh, yeah, here it is. There's like 5 copies in the world. This is one of them. You can look at it if you want to. I'll bring it to the workshop if any of you can come tomorrow. And it really, this project lays the groundwork for the collaborative history project that I'm currently leading in Chicago called History Moves. And History Moves is a community engagement project, a collaboration designed to share the work and power of interpretation. So we live at a moment where we have stories are in a lot of places, right? There's the StoryCorps, and there's and oral history happens everywhere. There's digital storytelling. There's stories everywhere. What we don't often share is the power of interpretation. So academics or even public historians take those stories and make them into something. And part of what my driving sort of interest in this work is thinking about how to share the power of interpretation, and to think about and to use what history can look and feel like as a way of doing that. And we're made up of an interdisciplinary team of historians, graphic designers. I work with a sound editor, folks in public health and epidemiology. And since last November, we've been working with a group of 12 women with HIV on their collective histories of both HIV/AIDS and the history of Chicago. So we sort of worked from the moment, really they wanted to talk about their lives as women living with HIV, but they also wanted very much to talk about how they were residents of Chicago and what that meant for them, and what it meant for them in terms of the way they understood and experienced HIV, but also the way they lived their lives as women from various communities. All of the women working on this project are part of the Chicago WIHS, the Women's Interagency HIV study, which is the longest running longitudinal study of women and HIV in the country, in the United States, and I think probably in the world. It started in 1993. It has sites across the US. A quarter of their participants have been in the study for all 20 years, which means that every 6 months they come to a clinic and they have a blood draw, they have a gynecological exam, and they answer a set of qualitative questions. So that means that they've come every 6 months for 20 years. They've come 40 times. They've never missed an appointment. So that to me already says, like, if you don't see that as a way of responding, as a way of answering apathy, like, I don't know what is, like, what is that? That is like a pure commitment to understanding themselves as part of their own care. And we've created multiple presentations of the work, and I'll play some of it for you today. There's this book, the sound you're about to hear. We're working on a radio piece. And hopefully by the end of this calendar year, a group of students at the University of Cincinnati are working on a set of modular public displays that we'll be able to take around the city of Chicago and set up in various locations. Students are quite excited. And in fact, the students in Cincinnati had to pitch their ideas to the women, the WIHS women, a couple weeks ago. And I think it was the first time that what for me was really clear is that the women who have been part of this project really saw in these students something about themselves that they were so excited to be able to see these young people sort of taking up their stories and imagining how to present them. So just a little bit of history about Chicago. It was not until 1988 when the number of Chicago women diagnosed with AIDS hit the 100 mark. So there's a sort of particular history here. And it was this was only 3 years after the term HIV was in full use, so it's not entirely clear to me when I look at the epidemiological data what I'm looking at, because the language isn't quite clear enough. But it was definitely not a huge epidemic among women. Men were the majority of people who were infected, and they were, at the time, identified as gay or bisexual. Today, we might call them men who have sex with men, and they were diagnosed at a much faster rate. By 1988, there were over 1,000 reported male cases of AIDS in Chicago, so a 10-to-1 ratio. And most of the women you're going to hear from today were among these first 100 women. So that's something I sort of figured out at some point. And many of the women you're going to hear from are now in their 50s, which also speaks to the reality of the changing epidemiology of HIV. We sort of know very clearly that people over the age of 55 are among some of the fastest growing populations of people living with HIV/AIDS. And the majority were part of the Black and brown migrations to the city of Chicago over the course of the second half of the 20th century. And the white women were sort of experienced that migration as well, although they experienced it in a different way. They experienced the way that racial segregation moved across the city and pushed them out of certain neighborhoods. And so what is clear to me in listening to this work is how much the reality that Chicago is one of the most racially segregated cities in the country in the United States really did mean something for what HIV/AIDS looked like, particularly for these women. So this is a quote from Sherry, who wants to, in some ways, she's going to push me to defy my statement about racial segregation, although she tells these amazing stories about what it was like to live in Cicero, which is a neighborhood that went from being all white to being majority Latino over the course of her lifetime. Sweet Pea migrated to Chicago from Mississippi in the 1970s as a 17-year-old. And I was looking back at her interview. She'd intended to get to Canada, but I don't think she made it far north enough. She was diagnosed in June of 1992. And this is a letter that she wrote on the anniversary, the 20th anniversary of the WIHS study. And it's about Jim Crow and about her experience as a young Black girl in the South. And that is a picture of the home she grew up in Hernando, Mississippi. I'm going to play her.
My father wanted the best for us, going to school every day, but they had a 3rd and 4th grade education. My parents did. But I always told my parents we came out okay to have that, but they couldn't teach us how to read. anything like that, help us with our homework. But we always said we made it.
There's a line there. I think she meant to write Jim Crow law, but she wrote I am Crow law. This is the sound is from a woman named Marilyn, who was one of the first women in the WIHS study.
I ran away a lot, and then at the age of 13, I was in a school for bad girls. I was in the Adi home. It's a place in Chicago for children who are supposed to be, it's just like the Department of Corrections, but this is only for children.
Part of what we did, and you can see, is we trained women to do oral histories with one another, and I'll play a pair who were interviewing one another, and you can sort of see what happened in that. And then we transcribed the interviews, and we asked the women to go back into their own collection of photographs and to give us and bring us images that they thought spoke to the parts of the interview that they were most interested in. And we did our own historical research, and then we brought those photographs and showed them to the women. And this photograph of the Audi home, circa 1967, we brought it in to show it to Marilyn, and there was a moment, she was sort of like awash with emotion at seeing this photograph, and she was like, I wonder if one of those girls is me. And she said, she's a woman in her early 60s now. She's about to finish her bachelor's degree at Chicago State University in public health. And she's getting ready to start a master's program. And she said, they thought I was a bad girl, but they didn't even know. Like, I'm not that girl. And it was this moment of like, what happens when we are able to see and visualize history and hear it, but I think also the fact that she was reading the transcript of her interview and not just listening to it that had that effect. We could talk about that also. But this, of course, is the Audi home and how much the criminal legal system is part of the story of women with HIV in Chicago. It's something that comes up again and again. This is Deborah.
It was the adults in my life not taking care of me. The adults in my life not teaching me how to take care of myself.
And Dolores, who grew up in Nova Scotia, lived in Montreal, and came to Chicago by herself in the summer of 1968, which is a pretty amazing moment. It's the just on the heels, just before the Democratic National Convention riots, the rebellion after Martin Luther King's assassination. And the reason she left Canada, she's in an Afro-Canadian family that is also First Nation. She was the darkest person in her family, and everybody, people were terrible to her. And so she wanted to leave, and this is...
I just always wanted to be around black people. Because in Montreal, where I was raised, it was en français, and Haitians, we didn't consider them our people. So when I was little, I would say, when I grow up, I'm going to move to the States and be around a lot of my people. And when I came here, people treated me so bad.
This is Marta, who is the daughter of a Mexican migrant and a Puerto Rican migrant, which is sort of only possible in Chicago, in part because Chicago has one of the most diverse and long-standing Latino communities in the country, and a place where there's both a long history of Mexican migration and Puerto Rican migration, although it's different because it's imperial, but you understand that.
But I thought, well, oh gee, I'm a woman now. I'm in a white dress, and I've got this big wedding. My first wedding was huge, and I thought, this is the transition over. Well, little did I know I was stepping into hell.
So, when taken together, the collection of voices speaks to how critical it is to understand the life history of people living with HIV/AIDS. And as we decided what questions the women would ask each other, we spent a long time talking about how to capture their experiences as HIV-positive people and their lives as Chicagoans and women. And were we not to have done this, I don't think we would have gotten this indictment of heterosexual marriage, which confirms what we know from lots of things, that in fact, heterosexual marriage puts women at risk for HIV in a way that we don't, in fact, often talk about. But beyond that, I think the deep background that these women gave one another, so they were really able to ask each other questions that, I'm a historian and I've written a book about AIDS. I've curated an exhibition about Chicago. I didn't know the things that they were asking one another, in part because they were coming up on the same streets. They knew the same stories. They had similar experiences, and they could ask each other those questions. And I think that what happened was really they produced a life history, a story of their experience with HIV that gave new models to the people who are the healthcare professionals who are working on the study, all of whom are amazing medical doctors, nurses, and public health people. But the women's life histories not only gave us a context for understanding their paths to HIV, but also the ways that HIV fits among what Paul Farmer calls structural violence. So we can see that racism, trauma, heterosexual marriage are all present here and need to be understood as part of what makes these women vulnerable to HIV. And Chicago's urban history as a city that witnessed profound racial and economic stratification over the course of their lifetimes really affected the course of their health and well-being. This next clip, this is Marilyn, who we heard from in the Audi home. This is a quote from a woman named Cordelia, who is whose family came up from Mississippi. She's the youngest of 6. She's the only one born in Chicago and has lived in the same house in Inglewood, which is now one of the it's one of the most violent and impoverished neighborhoods on the south side of Chicago.
I actually was doing everything to die and wouldn't die. I would drink. I would smoke reefer. I would do cocaine. But it seemed like the more I tried to die, the more I lived.
So, that may be a way of understanding risk behavior for women in some very not surprising ways. But I think that when it goes into this larger context, it starts to inhabit the space very differently. I would just like, so I'll start to, I guess I can talk for a few more minutes? Okay. So I would say that the next set of excerpts raise questions about what care looked like. So these first ones really raised questions about what we might call risk factors, but how these women's life histories meant that they became HIV positive. And we really went back and forth about how we asked questions about diagnosis, because it turned out that that was not the best way to understand these women's histories. So we could talk about that, like, what kinds of questions do you ask in an oral history that give you access to things that you wouldn't otherwise know about? And so in Chicago, part of that is very much about what's happening in Cook County Hospital, which is the main public hospital in the city of Chicago. And it's actually where the WIHS starts. It starts in the basement of Cook County Hospital in a room called the Radiation Center, where they basically pull aside a little space and they create a clinic for women and children with AIDS. So really how women were invisible in this period in many ways, I think, is important to at least recount briefly. So the earliest media reports of women and HIV focused on who they infected or put at risk, whether it was infant children or male sexual partners, rather than what it meant for them to be HIV positive, if it was after 1985, or dying from AIDS, if it was potentially after 1993. And women's invisibility was made even more critical in healthcare environments where services, all of which were very limited, were nevertheless designed for men. So that article, AIDS ward is open to women, that's not until like 1989. So it really does, and if you understand the sort of history of that experience, you can see why women with HIV/AIDS were invisible. And this invisibility, I think, was exacerbated by the intersections of racism and sexism in their daily lives and in the institutions around them. So despite what were often the very best intentions among doctors, nurses, the city healthcare system was actually unable to adequately treat poor people with AIDS who were made sicker by poverty and racism. This quote is from Marilyn about being in Cook County.
They came in my room, the doctor fully done, I mean from head to toe looking like astronauts, and told me I had AIDS. Didn't say nothing about HIV positive, and did I want to talk to a chaplain. And you know, if you're talking to you have to talk to a chaplain. What that means, you don't have long to live.
What I can't figure out from the interview is whether this was 1989 or maybe later. It's not entirely clear to me, because then you start to see how unclear the change of the definition was for healthcare providers who were working in places like Cook County. So it does raise this really interesting question about historical memory. Marilyn interviewed Deborah. So Deborah was the small picture talking about the adults in her life not taking care of her. And something happened in that interview. You know, these were women who have known each other for 20 years, but they'd never really had a conversation that they drove. They'd been part of conversations that the study had driven, and a study that is based on community input, a study that is based on the idea that they could control or make a case for the things that the healthcare professionals worked on, the PIs worked on, but that this was really the first time that they got to decide what narrative was going to drive the interaction. I think for many of them felt very exciting.
Because nobody wanted to be with the AIDS patients in Cook County Hospital. So what they do, they trained the AIDS patients to go sit with the AIDS patients.
Exactly.
Because we knew we needed comfort.
Exactly.
So we took these classes and we went and we comfort our people.
I'll end with this slide, which is all of the women who received their care at Cook County Hospital. The first day we met had these orange cards. And I said to them, you know, what are some of the things that you have in your life that help you, that are like the material culture, the objects that you most associate? And they all took out their wallets and they pulled out these cards. And I was taken aback by it for many reasons. One, I felt like the meaning of this orange in 2014 is so different than the meaning of this orange from 1990. So there was no way that I was looking at this orange at the moment that I was there and not thinking about two things, thinking about Guantanamo Bay and thinking about Orange is the New Black. And there's something sort of perverse about that combination, except that it is so much about how the criminal legal system has changed the way we think about that color. and what it meant for these women to have it, and that the card says, always bring this card with you. And they did. And Deborah said of this card, I have 3 numbers in my life: my social security number, my penitentiary number from Dwight, which was where she was imprisoned, and my Cook County number. Those are the numbers that define her. And part of what she was able to do through this project was think about the ways that she would define what those numbers were. And so I think where I'd like to end is to talk, to just raise again this question of what the differences between how we will write the history of activism and how we will write the history of service provision that really tries to intervene in the structural inequalities that affect the lives of these people. And so it sort of ends for me with 2 stories. 1988 was really the beginning of a changing point for Chicago women. It was when when the Children with AIDS program was opened at Cook County Hospital that then ultimately became the WIHS in 1993, and the Chicago Women's AIDS Project, which is called CWOP, was first created to provide support groups for women living with HIV. They were racially mixed organizations. They were in racially mixed neighborhoods, and what it meant for that to happen for women with HIV, the majority of whom in Chicago were African American, really raises some important questions about how service intervenes in people's lives. At the same time, local feminist activists, many of whom were white lesbians and members of ACT UP Chicago, or the precursor in Chicago is called DAGMAR, Dykes and Gay Men Against, the R could be repression, racism, or Reagan, also began campaigns to demand care for women with HIV in the late 80s and early 1990s. And in 1990, they threw mattresses into the street in front of Cook County to protest the exclusion of women from the AIDS ward, and hence that article, which says, well, it wasn't about those AIDS activists anyway, which is not true. But their protest worked, and women were admitted and ultimately died on that ward. But I was really struck as I listened to these women talk. I have many, many hours of recordings. Not a single woman mentioned ACT UP. And what that meant for me as somebody who's been committed to telling that story and what happened with that disconnect. And I think it really raises a set of questions about how radical activism in the form of civil disobedience addressed the service needs of the most disenfranchised people and communities. And it raises this question of how we're going to record this alternate change-making work of women of color with HIV. There's many more stories that I could play you, but I think I just want to end with 3 of these last clips, and we can then open it up for conversation. The first one is from Mary B.
I thought it was a death sentence too when I first found out about it, and it ended up making me a better person. I ended up becoming stronger and being more health conscious, and without drug use, and being more mindful and more aware of my body and the things that I need to do for me to stay healthy.
This is Bobby, and I should just say, I was the first person with Sherry who we interviewed, we sat together, who she'd ever told that she was HIV positive besides her doctor.
My son went to his dad and didn't know that I'm HIV positive. My other 2 children don't know that I'm HIV positive. My mother doesn't know. No one knows. My brothers don't know. And I lost 2 brothers from HIV.
And then this is Mary C.
So I'm standing by myself without a husband, but I still have those kids. So I'm finding who I am as a woman now, searching for the last 5 years, I guess. Finding this woman that's somewhere inside of me that I'm not even sure who she is or what she would like or what she would like to do, so I'm this late stage, I'm still looking for that woman within me.
They are all still surviving, and that's the title that they wanted the book to have. And I think it really captures for me the realities that their lives are are defined by HIV/AIDS, but also by so many other things that shape the realities of how they experience healthcare, how they experience Chicago, how they experience having children. Some of them have children, some of them don't. But it really does sort of speak to what I see as a legacy of AIDS activism, which comes from people like Michael Callan, who talk about surviving and thriving, and what that means in this context for these women, I think is part of the history that we still need to write. Thank you. Yeah, please. I'll stay on this side. Okay.
So thank you very much, Jennifer. What important material and such an innovative way of doing history with its actors. So we'll have a question period now of about 30 minutes. Please raise your hand if you would like to ask a question, and the microphone will come to you. Questions sont les bienvenues dans les deux langues officielles. Des questions en anglais seront traduites en français, mais pas par moi. Questions are welcome in both official languages. French questions will be translated into English. Also, just to note, this event is being video recorded. If you would like to ask a question but not be recorded, that's fine. Just approach Tom or Katie afterwards, and we can have you edited out of the material. So, questions, please. Yes.
Sorry. Hi, thanks for your talk. I enjoyed it so much. It was really inspiring. My question is about asking you to expand on this shift from doing activist histories through looking at direct action to service provision. And oral histories methods, obviously, are sort of your focus here, but it seems there's also sort of a story of other kinds of methods or sites of study. And I was thinking of these hospital cards, which is such a moving and stunning image in opposition to like an ACT UP t-shirt, right, that we saw in some of the other images. So I'm wondering if, I just wanted to sort of invite you to kind of expand on some of those other kinds of sites and that move that we need to make as historians looking elsewhere, perhaps.
Well, that's such a great question. Well, clearly, I mean, I was very interested in material culture, and obviously those cards sort of symbolize that. And then when you contrast the cards to the t-shirts, I mean, it's the perfect example of what can happen when you look outside of a traditional archive, although these would sort of fall into that category. And oral history gives you some access to it. Part of me wonders if it is in part about this model of thinking through how to let go of the interpretive power that I have as a historian. And I go back and forth. I mean, just being completely honest, like part of me says, half of the time I'm like, well, I'm going to let that interpretation happen and then I'm going to sort of take it in. And half of the time I can't stop myself. Like I just, so like at first when we would do these oral histories, like in the first one that I did, I just asked questions during the oral history. I was like, why are you doing that? I said to myself, but I was just doing it. It was like, I'm an oral historian. I ask questions. That's what I do. But that wasn't the point. And so part of it is, and then I really trained myself to not do that. At the same time that I recognize that I do know something. It's not like I want to step out of it and sort of, like I'm not so naive as to think that things can just speak for themselves, but the opposite of that isn't that I should speak for it. The opposite of that, or the solution to that, is that we should figure out ways to give lots of people ways of interpreting that. So for us, I should say the method, the importance of transcribing the interviews and giving the interviews to the women was, I think, one of the most important things that we did. And I'll say it in two ways. One is when the women we worked with got these pieces of paper, these printed documents that had names like Mary's interview and the date, you know, like they're professionally transcribed. We paid some money for it. And you compare it with how much Annie struggled with writing this document. What it meant to see their words on paper had power. So we talk a lot about voice, and I think voice is incredibly important, and it's moving, and I don't want to lose that. But the fact that we had them transcribed made the words feel almost more meaningful. And I'd say just two other things about that. One is, the method, and you can see it if you look at the book, the graphic designer I work with uses typographical interventions on the excerpts that they selected. Right? I have very few words in this book that I wrote. Most of it is chosen by them. And so what we did was everybody got their interviews. The women who were literate enough read them and made the selections of the passages that they wanted to highlight. And the women who couldn't read well enough, we read back from the transcript to them, and they made selections about what they wanted. So I think there's something there about, it's about materiality, it's about voice, it's about printed voice versus oral voice. So there's something about, though it's a different way of thinking about the materiality of it that's not about the ephemera, but is in fact about, that's the best I can do. I've silenced everybody.
Other questions?
Hi, I was really interested about the story you told at the beginning about talking to the funders about, you know, like having to choose between history or medicine, and just, I guess, also like as a public historian, like how do you deal with that disconnect between like what seems so obvious like within the academy about like the importance of this like historical and activist work, and then like the realities of the people you come across, like when you're getting funding, or like how you're introduced, you know, by the consul, the person from the consulate. I thought it was interesting as well, like the story they tell about the history of AIDS in the U.S. Like how do you deal with that is my question.
Well, I haven't gotten any of the money yet, so
okay.
Maybe my answer won't be very. Maybe my answer isn't very convincing. You know, part of me wants to use the easy answer, which is that if, you know, I'm a historian and I believe that if we don't know our past, we're doomed to repeat it. But that's not going to get us very far. That's just, but it's so tempting. But I think part of it, at the same time that I want to resist what it means to sort of think about assessment in the way that, you know, many of us probably deal with, like, can you count how many people saw this and think something different because of it? That doesn't seem very useful either, to sort of take up that method, that behavioral scientific method. I've been thinking a lot about, and it's something actually that comes out of a project called Imagining America, which is a collaboration between humanists and artists in universities. Something called outcome harvesting, which is a model of thinking about how to actually document what has happened as opposed to making claims about what will happen. So it actually then means that you would go back in and look at what did this mean? So we know from the women who were involved in the study, in the project, they've done presentations so they're just a small, tiny little cohort of a bigger study. And now like all of the women in the WIHS want to do the project. Every single one of them. And I'm trying desperately to raise more money because it's not, because it costs money to transcribe the interviews, and we have actually developed a model where we pay them stipends to be part of the project. We pay the folks at the WIHS who are helping us coordinate, because I think there's also this idea when you do community engaged work from a university, you're going into organizations that really do need those resources. And even if I'm from a very strapped public university, it's still got a budget that is 10 times larger than, you know, the budget of my department is bigger than the budget of some of these studies. So really thinking about how to do that kind of ethical work, and to then make funders see that this is a way of, that part of what I'm trying to imagine is that public history can be a form of service, not because it helps, not because it provides students with an opportunity to do this work, but because it actually gives something, it provides new language, new mechanisms for organizations doing the service provision, doing the advocacy, to imagine a historical network that is much larger than the one that they may find themselves in at this moment. So it's a little bit of that. And if I can convince somebody who gives away money for MAC makeup that that is what they should be funding, then, you know, that's sort of the question. But it's a very complicated one, and we could talk about all of the ways that the funding, the philanthropic world has defined for us a whole host of things that do not reflect the reality of the things that people need. I mean, you need really only look at gay marriage in the United States to see that. And now what's happening with the way people are talking about all of the work that needs to be funded, because it hasn't been funded in part because of that. So maybe expanding that notion, but it hasn't totally worked yet.
Hello. I was wondering if you could talk about the duality of the language in the title of the book, Still Surviving, like in the context of trauma, where, you know, still surviving is an achievement, but still surviving is also like a continuous process of healing. So I was wondering if you had thought about that.
I feel like you should answer that question. No? You're not going to? Maybe later? Okay. We had a long conversation about still surviving, and I you know, the exhibition that I curated is called Surviving and Thriving, as an homage to Michael Callan. Yeah, there's no, part of what I guess I realized was that there's no hagiography in this work. Like, no one's gonna come out fully, like, looking like a rose. But it also raises this question for me of, I don't know, I have a colleague who I just actually heard give a really interesting talk yesterday about Katrina, and how the discourse of resilience has been used in Katrina as part of the neoliberal response to Katrina. And that the other place that you see resilience, besides New Orleans, is among children. And then I read an article in the newspaper today about the resilience, questioning the resilience of children and around forced migration and refugee crises. And so part of me, at that moment, you know, there's like this, how do you use the term surviving in a context in which many of these women do really think about and take incredible pride in being at an undetectable viral load. And the way that they talk about that and the way that they understand that is best understood in relationship to the for many of the women, in terms of how they think about or whether they are continue to stay clean or whether they are using, and how that sort of goes back and forth, as well as what it means for them to have stable housing, as well as what it means for them to have their kids with them. So it does, I think, when they chose the title, I'm Still Surviving, it was both in reference to HIV, but so much in reference to all of these other things that for me, it changed the word. In the history of HIV/AIDS, it changed that word's meaning for me. Because it said, like the stories about having their kids back is a pretty powerful one, and what they do to get how much they work to get their kids back. And the reality that that is a completely unstable relationship. But it's also true that the conversation about housing is also very much a part of this. And the transformations, not only in their own personal housing situation, but the transformation in their neighborhoods. So Cordelia, who is from Inglewood, talked about what it was like to live in Inglewood when she was born. She just celebrated her 51st birthday. So to talk about what it was like to be born in Inglewood and come up and to be on a block that had a house in every lot, and now to be on a block that has 7 houses left. So what it means in that context too. So, I'm not a historian of trauma, and I don't know enough about how it functions historically to answer that question maybe in the way that you're asking it. But I do know that what survival means is so much more than just getting by, that I have to kind of, its meaning is really different in this context than the one that I think if you looked it up, it would say. Yeah. Maybe that answers the question? Yeah. Some? Okay. You turn the mic off? Okay.
Thanks. You said you had interview. There was interview for 20 years, twice a year. How long were the interviews?
The interviews that the WIHS does, or the interviews that we did?
Both.
The interviews so it's interesting. The interviews that the WIHS does, it's a long. I mean, I've never been allowed to see the interview because it's part of their protocol. The women did talk about the fact that sometimes they know what all the questions are because they ask the same questions, and sometimes they know if they're really not in the mood to stay for a long time, they won't answer certain questions. Or they know that if you answer yes to that question, then you get like 10 other questions, and so they'll say no even if it's not true. But that's a way of them like saying, this is how I want to be in this space. And it's interesting because, of course, part of what we did in this interview, and it's hardly original, I mean, it's actually foundational to the work of oral history, is that we have and foundational to the work of queer people, we had a long and continuous conversation about consent. So what it meant to make decisions about which questions you would answer and which questions you weren't going to answer, how they consent to the way their words are represented beyond the interview, right? So this is all, this has all been approved by them because it's their history. Our interviews, we worked, I would say we had many different iterations of things. We worked together 2.5 hours a day, probably 8 times over the course of a set of months. The interviews ranged from 45 minutes to 2 hours, and then they would flip, so they would interview one another in pairs. We had some follow-up interviews when they brought their photographs and we scanned them. We captured those conversations as well. So nothing like the 20 years of answers, but but they, as I said, they were in control of those questions in a way that they aren't in the other ones.
Actually, I'm wondering about the different things, but first there's the confidentiality aspect of it, and also the self-awareness that, like, I mean, if you do that for 20 years, at some point, you something builds up in yourself, and you say, well, okay, something's happening with this, you know, it changes me, and maybe it's changing something else or some other people around me. So and I'm connecting that to the fact that, you know, like you exposed the fact that ACT UP was kind of taking all the place media-wise, you know. So how that kind of sub effect was taking place in the population, you know, like from close people to larger?
Yeah. It's such a great question. I don't know the answer to it. There is definitely, though, I think for me, you know, I could tell when the women were like on script. And we all have scripts. Like if someone interviewed me, like they're going to get part of my spiel. You know, like I'll tell you this story or that story, this story, that story. We all have that. And then the question is and parts of interviews have that. And then almost all of them, there is something that happens where someone like goes to a different place. And you can feel it, like it's different, like it's not rote. It's not like the story you've told 20 times that someone's asked you about your diagnosis or whatever it is. So there's that. I don't know how to answer that other question. I guess I would put it back to you, like, what would be the way that you could get at that? Like, what would be the way? I'm not sure. I mean it, like, tell me what you're thinking.
Well, I think, maybe, you know, like, if they kind of developed a sense of awareness about their situation and situations of peers and all that at some point, you know, they get more acquainted with their situation and more comfortable with it and their identity. And also question of identity, it kind of developed in spite of the imagery that we had, you know, during the media. It's the same for today. Like the image of the HIV people, it's disastrous on the medias. So, and in fact, actually, when you were talking about the drugs, now with the drugs, the sad fact about it is that we don't exist anymore. There's no representation of ourselves as being, you know, existing. So it's all fabricated by the medias. So from their empowerment on their own speech, you know, maybe there's a way they felt it was, you know, making effect on people around them, at least, you know.
Yeah. I think that's definitely true. And I think part of what I think their decision, part of our, how do I want to say this? Our decision as a team of scholars and practitioners was to give form to their history and to use this method to do precisely that, to make them visible in this way that they are not, in fact, visible. But I do think it was in response to their own, like, it wasn't that we came with, like, this design and imposed it on them because they had done this. It was actually, it was much more iterative than that, and I think that's why it works. But it does, but the question of, but I think there's something in your question in part about undetectable viral load that is, I think, part very much of what we need to be figuring out how we talk about. And it does go back to this question of if biomedicine is going, if that's a biomedical model of how you treat and therefore prevent the spread of HIV. And if it has the potential to erase the reality of it, then it really does. But of course it doesn't, because we know very much that being a viral load undetectable means that your body has many other things that are being detected in it and are visible and made visible on the body and in the body. And, you know, so I guess that's really the question, is like, how do you represent that?
I don't know.
I don't know either. But I think even asking the question so much matters. Yeah.
We have time for one or two more questions. So I think there's one there in the middle.
Hello. Oh, it's very loud.
I know it's wild, right?
I had a question about, so you mentioned kind of the absence of ACT UP in their understanding or like their history of AIDS and HIV. So I was curious if there were, like, in the sense that in the 80s and 90s it seems to be linked to like a certain cultural and social canon that was formed around like art. And I was curious like what other narratives or like how they had like interpreted, especially like that there's been so much time passage now, and like in relation to the previous question, like how have narratives and like a sense of like this as a national or a local or a community experience, was there like any sense of like cultural like forms or like things that they had used to like, and discussion of things that they had used to think about their experiences? In like, was that part of the interviews? Yeah.
I mean, in the most basic sense, my answer to that is the one thing that we did hear was about Magic Johnson. We did hear about that. And about the proliferation of commercials, sort of scare commercials that were part of the late 1980s and early 1990s. And there's a whole, you know, like the sort of when testing becomes the drumbeat, right? So 1985, pretty universally, people are saying you shouldn't be tested because there's no reason to be tested because there's nothing that's going to happen. And likely governments and insurance companies will keep track of it, and then you will be fucked when it really is time. That starts to change, I would say. I mean, maybe it's AZT 87, but it does start to change around Magic Johnson's 92. So somewhere in there, 90, 92, it starts to change. And now we think that testing is like it's testing and condoms are the only things that you can do. I mean, and now we have treatment as prevention. So you can get tested, you can use a condom, and you can take protease inhibitors. And now we've heard that everybody should be on protease inhibitors. Everybody in the world should be. Every person who tests positive, and we'll see what happens if we really get to a model of TASP, of NF PrEP. But so there's that as a cultural reference to them. But it's interesting because, of course, the class dynamics make it such that the way that you're going to like their access to, in some ways, the women of the WIHS, their access to those worlds becomes possible through the WIHS, not before the WIHS. So something that happens in 93, I mean, obviously it's not just the WIHS that gives them access to it, but a lot of these women will talk about, like, they go to some of the they are on the community advisory board, they go to the big conferences, and they interact with people who are doing AIDS work all over the place. They are able to leave Chicago and see something else that they probably wouldn't have otherwise seen. So there's that. But still, it's not, I asked them all, like, it just isn't what they're, and part of me, you know, I don't want to just return to the simple argument about how deeply experienced and felt for all people in Chicago segregation is, but I do think it has a great deal to do with it. Like it's profound, it's housing stock, it's neighborhood line, it's the subway, it's the fact that there are people who live on the west side of Chicago who have never been to the lake that's on the east side of Chicago. So, and what that means for the kinds of cultural accommodations, public accommodations, like it is so profoundly unequal as to almost, I can't imagine that that's not part of what's going on. So it's not like ACT UP is failing on its own, like Debbie Gould has made this argument, I think, quite convincingly. Like, you can't say that ACT UP was racist and not recognize that, like, racism is suffused in U.S. like, it's everywhere. So ACT UP is not more racist than, but it was something about that disconnect that I just think, and it's obviously there are a lot of disconnects, but what that then meant is the things that they were talking about were more in line with what I've described.
Time for one final question in the public. There's one right there, okay. And then, of course, afterwards we can speak casually with me.
No. No. Oh, get the other mic. You want this one? Here.
Thanks, Jenny. I just want to say first a quick thank you for the validation of being a cultural studies student who has no funding for their PhD, who's doing work on the history of HIV. And the second thing, I was speaking to you a little bit about this earlier. I'm really interested in the way that people use metaphor to make sense of their illness. And sort of in the war of words between Paula Trickler and Susan Sontag, I think it's a really productive space. And in my own research, I'm looking at the use of sort of genocide and Holocaust metaphor that largely came out of art and culture production from New York, which is a really specific milieu, including lots of Jewish artists. So I'm wondering what sort of metaphors might have come into play in the projects that you've worked on with this very different group of people that are not talked about.
Yeah, no, I was going to say, why don't you keep it for a minute? I have to say, I want to go back and read some more of the transcripts, or maybe, I'll ask the women if they're okay with you reading them. I think that's a really fabulous question. And I don't know that I have an answer to it, but that's my own fault, not their fault. Because I haven't seen it necessarily. Yeah, let me think about it. I mean, there's definitely a conversation. I mean, I think the subjects that are most talked about are, but I wonder what the metaphors are. I mean, it might be prison. It might be something about incarceration. And it might be something about and that incarceration is a complicated incarceration because it's both actual incarceration and there is, I think, metaphorical talk about the incarceration of drug use and what that does to their minds and their bodies. There is a lot of talk about sex work, but it's interesting. Like they go back and forth. Like some of them are like, Sherry was like, "Well, I am not. Look at me." She's like, "I never did that because no one would pay me." But there was this like amazing moment where you could see that was part of how they understood their lives was through the sort of social conditions of their lives that made them, that connected them in one way or another to HIV. Religion is a huge metaphor that most of them talk about in various ways, that is not really here in the clips that I played you, but is definitely there. But it's a really great question, and it's one that now I'm going to go back and look for. So thank you. Go.
Sorry. Well, first of all, a few more final announcements, but let's thank our fabulous speaker one more time for a really important work. Thank you. So I just wanted to remind you that donations are essential for the continuation of the HIV/AIDS community lecture series at Concordia, and anyone can take donation forms as they exit the room. Also, a few final thank yous. The Vive Healthcare Consulate General of the United States at Montreal, Office of the President at Concordia University, Jason Milan for the poster art, the teaching... Woo! The teaching team of the HIV/AIDS course at Concordia University, Karen Herland, who I saw out there somewhere, internship coordinator Florencia Marchetti, yay, one of my students, and teaching assistant Nora Butler-Burke, Thomas Waugh, director of the HIV/AIDS project, and Caitlin Zozula, HIV/AIDS community lecture series coordinator. Thank you very much. Yay. For more information about the HIV/AIDS project and community lecture series, please visit the website, aids.concordia.ca, or find us on Facebook and Twitter. Come back on Tuesday, December 1st for our World AIDS Day lecture by artist, activist, curator, and archivist, curator, and activist, Sir Rodney at the Montreal Museum of Fine Arts. Once again, please speak to Tom Waugh if you'd like to participate in the small group workshop with Jennifer Brier tomorrow on the methodology and ethics of oral history. And finally, we welcome you to enjoy some of the snacks and refreshments at the informal reception as you leave the room and continue this evening's important conversation. Thank you for your support, and good evening.